High velocity thrust of a posteriorly rotated ilium is very important, and it is essential that you take the time needed to carefully adjust the patient so that the patient lies completely correctly. Both relaxed and locked, so to speak, are the conditions at the moment when the thrust would be delivered, and these are the places where you do not want the thrust to be directed. The first thing I do is lie with one hand here along his sacroiliac line and gently bend his knee until I can feel movement here. Only when that movement is clearly present do I ask him to straighten the lower leg so that it aligns with his lumbar spine here. It's not particularly important whether it lies somewhat diagonally or quite straight, because it will still point outward a little here, which is what really matters. Afterwards, I again place my fingers around L5-S1 because I want the entire lumbar spine locked, since no movement is allowed here. This is done by first taking his upper hand and placing it firmly on his ribcage structure up here quite laterally. First, he stretches the lower arm, and I move in to lift it up so that his arm lies under my armpit, and I hold on to his arm, specifically his upper arm, with my hand here. It is important that I bend my knees a little so that I make a clean, straight pull upward. When I perform a straight pull, he also makes a rotation as well. Okay, so I gradually descend here, maintain contact, and perform a rotation. If I cannot feel that I'm going all the way down or that some rotation is happening in the lower back, then I can create a side bend by stepping up here and pulling his arm upward. The side bend also helps lock things in here. I can make a small adjustment to the last part here. That's perfectly fine. Then he remains gripping his own elbow so that he is locked securely in place, and my hand, the upper hand, the one, slides carefully in between the lock he has created here and settles again down within the SI line. Afterwards, I seize hold of the lower leg, and I continue to twist it steadily until I can clearly feel that there is a rotational component actively taking place right here. Typically, it sits at about 45 degrees. Here I can clearly feel it, just like this. And I may gently lay the top leg as shown so that a little weight rests lightly on the lower leg, allowing the foot to be placed down on the lower leg. Perhaps now it should be such that if I release him, he lies in the middle of the table or on the table and relaxed. If the patient is lying there and bracing against me, or if he ends up drifting out too far, then you simply have to restart the entire procedure from scratch. I move down to this spot here. I have him securely locked here. The next thing I do is rotate his entire body here from head to hips. That means both his spine and his pelvis so that his ilium points downward, because then I can perform my thrust by simply letting my weight press down on him, and the rotation will be anterior, i.e. forward rotated. So I'm holding you here, and I'm just telling him that we'll move you out again. If you want to do this, what should you say to stay extra steady? You can ask the patient to turn their head so it points up toward the ceiling. Turn your head. It's not that we manipulate up here, but it helps the patient feel a bit more stable in their neck. I have gently rotated him all the way around in this very place. I slowly place my forearm on the crest and am careful not to go too far down so that it remains right up at the crest. And a male crest is, as it happens, quite high here. Please be aware of that. I keep it right up on the very edge of the crest with my arm and the palm facing upward. Thereafter, I ask the patient to take a slow, deep breath, and as he gently exhales, I can tell whether I am at what we commonly call the barrier or at joint play, where I gradually shift from slackness to tension, as you might say. Take a deep breath again, exhale, and relax. And in a given way, what should one say in this context? Exhalation here, please. Take a deep breath again. We then perform a manipulation by placing a weight down carefully over this pathway. Occasionally, if the locking mechanism is present and you do not truly feel that the patient is experiencing tension, what should you say? Or how might you guide them to relax sufficiently during this expiration? Then you can perform them consecutively, one after the other. I will simply attempt to demonstrate how it looks. Please take a slow, deep inhalation. Now exhale gently and allow yourself to relax. I don't really feel it properly. One more time, so that I can somehow manage to get through with my first thrust, and then I can perform another one immediately, without him even breathing a single breath at all, you could say.